Chronic hemolytic anemias present differently as compared to acute hemolytic anemias. The acute hemolytic anemias, as we saw, can produce sometimes medical emergency, a crisis situation. But generally, the chronic anemias are well tolerated, and patient only has, in a few circumstances, real medical emergencies. Clinical features of chronic hemolytic anemia: chronic, ongoing, or recurring hemolysis which leads to anemia. Patient may have dark colored urine, there may be weakness, fatigue, shortness of breath, dizziness, lightheadedness, sweating, palpitations, and there may be venous thromboembolism in some situation, for example, PNH. Then you examine, you find pallor, there may be jaundice, tachycardia with bounding pulses, tachypnea, bronze diabetes because of the repeated transfusion in some patients, resulting in iron overload situation called hemosiderosis. There may be gallstones, particularly in patients with hereditary spherocytosis, and there may be skin ulcers in patients having sickle cell disease. There may be splenomegaly, especially in hereditary spherocytosis, chronic lymphocytic leukemias, and SLE patients. Now, the hereditary reasons for chronic hemolytic anemias can be membrane defects, hereditary spherocytosis and leptocytosis. There can be hemoglobinopathies like thalassemia or sickle cell disease. There are acquired conditions which can produce chronic hemolytic anemias, for example, immune disorders which may be primary or which may be secondary, toxic chemicals and drugs like ribavirin, and then microangiopathic conditions, for example, prosthetic valves, DIC, in some patients, TTP, and hemolytic uremic syndromes. The hemolytic uremic syndrome generally produces acute type of hemolytic anemia, but in some patients it may be chronic as well. But generally it's an acute hemolytic anemia. When you get a patient with chronic hemolytic anemia, get the CBC. Retics may be increased only if the patient may have developed folic acid deficiency. Retics may not rise. The manual film examination will show microcytes if the patient has chronic anemia and losing hemoglobin, and with that losing iron, they may develop iron deficiency. There may be microcytes. There may be macrocytes because there may be large cells like reticulocyte in the circulation. Maybe schistocyte in situations like TTP, DIC, or hemolytic uremic syndrome in prosthetic valve. Spherocytes may be present in hereditary spherocytosis, and we have to see this CLL. We can see on peripheral film whether CLL is there or it's not there. So peripheral film becomes very important in chronic hemolytic anemias. Get some chemical tests like indirect bilirubin may rise, the haptoglobin may disappear, the LDH may rise, there may be free plasma hemoglobin, there may be urinary free hemoglobin, and there may be urinary hemosiderin. Abdominal ultrasound is important because in cases spleen may enlarge but may not be clinically detectable, should be seen on ultrasound. Hemoglobin electrophoresis, sickle cell screen, and red cell survival time should be done, and direct antiglobulin test, indirect Coombs test, cold agglutinin, and in considering if the patient has chronic variant of PNH, flow cytometry may be used to see for CD55 and CD59. A flare test may also be done. When you get a patient with chronic hemolytic anemia, what you can do is identify, avoid, and treat the underlying cause. That is the most important. Mild cases require only observation, nothing much. But in severe cases, when the oxygenation is compromised, you may give oxygen inhalation, hydration. Patient may require transfusion. The Paxil transfusion should be given, and in conditions where multiple transfusions are required, one should give iron chelation therapy as well. And folic acid should be added because increased turnover of cell may cause a relative deficiency of folic acid. So folic acid supplement may also be provided. And as already mentioned, that patients who are losing hemoglobin through the blood, they may also require iron supplementation. Corticosteroids or plasmapheresis, IVIG, or rituximab can be used in autoimmune type of hemolytic anemias. And then in patients who are not responding to standard treatment, splenectomy may also be one of the potential treatment policy. And then iron therapy in persistent hemoglobinuria. So this is what we do in patients who present with chronic hemolytic anemias.